I'm Nazlee Zebardast, Assistant Professor of Ophthalmology at Massachusetts Eye and Ear and Harvard Medical School, and Director of Glaucoma Imaging at Massachusetts Eye and Ear. Of course. So glaucoma is a highly heritable disease, and it's a complex disease. So a lot of people may not realize that, but it's actually one of the most inherited of all complex human diseases. And what's interesting about glaucoma is that it has two forms of genetics. So we have the Mendelian genetics, which tends to be single gene, rare mutations that tend to affect younger individuals like congenital glaucoma. And they have high effect sizes. On the other hand, we have adult onset glaucoma, which, is the complex disease that tends to affect older individuals and has both a genetic and environmental component. In the adult form of the disease, we have many mutations of small effect sizes, which we think in aggregate or in combination affect someone's risk of disease. So this was an analysis of the OAT study. The Ocular Hypertension Treatment Study is a landmark trial that randomized individuals with ocular hypertension to receive IOP-lowering medications or to be randomized to observation. And they determined that over a 20-year observation period, early treatment with IOP-lowering medication reduced people's risk of developing primary open-angle glaucoma by about 60%. So this was an analysis in collaboration with the Ocular Hypertension Treatment Study Group, as well as researchers at Mass Eye and Ear. Of course. So just a little bit about polygenic risk scores. These are scores that have been constructed for a number of complex diseases. And the idea, again, is, like I said, there are many mutations potentially or risk variants across the entire genome. And in combination, we think that they increase someone's risk of disease. So we can create an aggregate score, which we call a polygenic risk score, by summing up the effects of these variants across the entire genome. And a fair amount of work has been done so far on these polygenic risk scores, including by our group, where we have used them essentially to identify people at high risk for disease. So we've been able to show that a higher polygenic risk score is associated with greater risk of disease, more severe disease, for example, earlier onset of disease. But what hasn't really been done yet is looking at the opposite of that. Can we use a cutoff of a genetic risk score or a low genetic risk score to identify those that are at low risk of disease? And the motivation for this really comes from the fact that we have, a large population of individuals in our clinics that are glaucoma suspects. And the ocular hypertension treatment study also showed that even though early treatment reduced people's risk of developing glaucoma, a large portion of people did not develop disease. And additionally, of those that developed disease, most of it was mild. So we were motivated by this to understand whether we could use a genetic risk score to understand who are the people who are really at low risk and who, potentially don't need to be monitored or treated as aggressively. So what we found was that we were able to identify a cutoff of a polygenic risk score, which was able to separate out people who were at high versus low risk of developing disease, specifically, visual field loss or functional changes. And additionally, we were able to show that even within a high clinical risk group, if you separated people by polygenic risk score, you were able to tell who needed early treatment versus those that were not really going to benefit from early treatment. So I think this is really significant for a number of reasons. One, it shows us that we can separate out people's risk based on their genetic risk of disease. And secondly, it shows us potentially who are the people when we combine genetic risk with clinical phenotypes, who are the people that may benefit most from early treatment and versus those that can be observed. And I think this is really important, not only from decreasing potential harm of excessive treatment to patients, but also reducing cost and need for monitoring of individuals that probably don't need to be monitored as aggressively. So I think that, we have problems in both ends of the spectrum. On one hand, we have individuals who are not getting the care that they need to early enough. Glaucoma is still the #1 cause of irreversible blindness worldwide. And more than 50% of people who go blind from glaucoma don't come into care early enough. And that's true even in the United States. So I think being able to identify individuals who are most likely to lose vision is extremely important. But on the other hand, we have this, it's almost like a pyramid. At the very top are all these people that have mild disease or who will never lose vision, but are getting unnecessary care and necessary monitoring. But then at the bottom, we have those individuals who are going to lose sight permanently, and we need to be able to identify those. So I think we can approach this from two angles, and I think that's what's so important about this study is that we show not only is genetic risk important for identifying those that will lose vision, but it's also potentially a way that we could say, you're at low genetic risk. You may not need to be seen once a year or twice a year to monitor because your likelihood of needing treatment or losing vision is relatively low. No, I think I really think that this is something that's coming to our clinical practice. There is a lot of studies coming out about genetic risk scores, and I don't think this is something that is going to go away. It will change the way we practice medicine, and I think it's really important to do studies like this to understand how we can use these risk scores better.